gotten into the cardiac program at NYU Bellevue. When I went through my training, I rotated through the plastic surgery service, and it seemed to me like they were having a lot more fun than the cardiac surgeons were. And in reality, they were terrific surgeons. They were always in the operating room, always doing surgery, rarely doing anything else. And surgery is what I always wanted to be, a surgeon, right? So I changed my field, and I'm really happy I did. When I go to my meetings with my former chief residents at NYU Bellevue, they all wish they went into plastic surgery.
So how much did that prolong your? I mean, how far into the cardiac surgery were you?
Well, it didn't prolong anything because back in the day that I trained, you had to have your boards in general surgery in order to go into plastic surgery. So I'm double boarded. I'm boarded in both general and plastic surgery. So it took 7 years of training, but it always did back then.
Can you can you kind of comment, because I see a lot of people that are cosmetic surgeons. Can you kind of delineate the difference between a cosmetic surgeon and
Mhm.
what's required to be that versus a plastic surgeon?
Correct. Plastic and reconstructive surgery requires training in both general and integrated plastic surgery now. Cosmetic surgery training is through the dermatologic boards, dermatology. So those per people that are cosmetic surgeons specifically are dermatology trained, and we are plastic surgically trained. And then there's facial plastic surgeons that are ENT trained. So we cover the gamut, head to toe, with all sorts of procedures that we can do, both head to toe. Dermatologists are really supposedly limited to skin, and ENT plastic surgeons are supposedly boarded for facial plastic surgery, not body. Now, people
But real,
practice other things, but
yeah, really, I mean, when you have MD,
that doesn't
you
mean that
can't.
their training, was in those particular fields or their expertise.
So let me ask you a little favor on your camera. Can you tilt it just a little bit more so your head is just a little bit higher in the screen? That's perfect. There's a thing called the rule of thirds, and they use it in all cinematography and photography. And it says your eyes at one third level. If they're lower, then you lose a certain amount of authority emotionally when people look at something. And if you look at any film, you'll see that that's really kind of carried through. Now you'll think about it next time you go to watch TV
Yeah.
or a
Well,
film.
here, I was looking at you, not myself.
Okay, so I'm just kind of interested. You developed the whisper lift. Can you tell me what about inspired that technique, and how does it differ from a traditional facelift?
I developed a thing called tumescent facelifts, which are done under sedation, not general anesthesia. That's a technique where an IV is inserted into a patient and they go off to sleep with some medication, but they don't need to be intubated and put on a respirator, so to speak. So that's not a general anesthetic. So I've always felt that's safer for patients, and uh, lower risks in terms of the anesthetic risk, lower risk in terms of infection, lower risks in terms of hematoma, things like that. And In my hands, I felt it to be an extremely effective way of pursuing facial cosmetic surgery.
Does that lower the anxiety for patients?
Yes, I think it does. Nobody likes general anesthesia, the
Yeah,
concept, right?
yeah.
There's a lot of blood pressure changes that can occur, a lot of issues that can occur for medical clearances. When you're being cleared for a procedure, when you know that you're having IV sedation, there's less risk. And
Hmm.
that's been borne out statistically.
What distinguishes, in your view, a good facelift from a truly great facelift?
Sometimes it's the simplest uh, reaction that people have afterwards. In other words, boy, you look so much better, not you look so different. I think we all hear that and want to hear that as surgeons, right? That patients got complimented. Um, but, you didn't want them to say, like, what the hell did you do? That's not a good reaction, right?
Right.
That I think is the mark of great work.
So, your work on areola sparing mastectomy
Hmm.
has impacted reconstructive breast surgery worldwide. What motivated that research? And can you just talk about how that works? What do you do? I mean, because you have a mastectomy and there's just not the blood flow to the areola. You take that out, there's not a lot of blood flow. Tell me about what you've done that has kind of revolutionized that.
Yeah, Dr. Rasha Simmons and I had worked on that paper together more than 20 years ago now. And her and I were working together in the OR, and we had a patient who was coming in for bilateral mastectomies because they had genetic propensity towards breast cancer. And her and I both noticed that the patient had um, the nipple areola complex was smallish, and the breast was smallish, meaning, A, B cup. And we both looked at each other and said, maybe we should think about approaching this through an incision under the breast rather than the traditional approach where we go across the chest. And maybe if you can take out the breast through that approach, we can preserve the nipple. And it worked. And as it turned out, it's become almost standard for most patients undergoing that procedure.
Yeah, I actually didn't think that there was I'm another way to do it. So it used to be
Yeah.
just always across the top. Huh?
Yeah, no, and what we did at the time was to study it. We had her do some biopsies under the nipple areola complex and do some frozen sections to verify that there was no involvement of the nipple areola when we did the mastectomy and the
Hmm.
reconstruction, and it proved to work. It's just one of those what if moments, and that's
Yeah.
usually the case in most advances.
Well, and I guess the concept of doing the biopsy in advance on the areola was a key thing in that whole process to find out, can we spare this, or can we save it, or can we not, or do we have to
Yeah,
just
no, we did it intra-op, in the operating room. It wasn't done ahead of time. It was done during the mastectomy, and the specimen was sent out during the mastectomy to verify that we didn't have to remove it. And I
well, how much of your time?
remember, I remember having at the time, after that, having taken care of a very major media personality that required this surgery, and saying to myself, boy, this really better work because we've got a major person now that's doing it. And of course it did, So, but even the best innovators have have sleepless nights.
Right. Yeah. So how much of your time do you spend? So you're a professor at Cornell, is that right too?
That's correct. Associate professor of surgery, plastic surgery at New York Presbyterian Cornell.
So how much of your time does it take to do you do at the being a professor versus in your private practice?
Well, it's usually together, meaning the residential staff rotates through our offices while we do our private surgeries, and that's the best way for us to teach them.
Is there how has academic medicine influenced your approach to private practice, or even has it influenced your approach to private practice?
It's very much influenced it. You know, we as academics, just to give you an idea, I have to do 101 category 1 hours a year in order to maintain my academic privileges at Cornell. What that means is I have to study 100 hours of courses every year. Just think about that. That's
Hmm.
2.5 weeks of study just to maintain my privileges. So we're up on things. I'm also do some editorial work for our major plastic reconstructive surgery journals, and that really gets me to review some of the most newest and best techniques out there. So it
So
really
what?
does help.
Yeah, I would think that just constantly being forced to do the training sometimes would really assist you in staying up on what the latest is in your field.
Correct.
So, what do you do when someone comes into your office and they bring in a picture of somebody, let's just say Kim Kardashian? They say, "Can you make me look like this? And I want to have breasts like this, and I want to have this figure." How do you deal with those kinds of? Do you have that kind of situation? And how do you deal with
Not
it?
not very often. We hear about you read about it. I think that's something you read about more than see. Most people I care for are pretty realistic. I don't advertise. You're not going to see me on in some social media post. I don't do any of that. Most of my clients are referred by other clients, so they're vetted. They're not the run-of-the-mill person that might be influenced by an influencer, so to speak. So I don't see that very often. I
Okay.
find that most people are very rational, at least my clients.
Um, what innovation or advancement in your career are you most proud of, and why?
Well, I think it was, doing the tumescent facelift approach, doing it without general. That really made my career. Most of my surgery is related to cosmetic facial surgery. I'm also very proud of the areola sparing mastectomy, which is really uh, s- a major advance for women.
Right. I think
That's a
most
major,
women are
yeah.
concerned about that. When they have that kind of surgery, that they're losing their nipple
Hmm.
is not something that you can you can fake it, but you can't really. I mean, the real thing is I would think would completely change a woman, or,
Absolutely.
or I mean, maybe not change her, but change how she feels about herself.
Absolutely. And even though I don't really no longer do, reconstructive breast surgery like I did before, um, yeah, I'm very proud of that.
So here's one thing that I kind of just picked up when we were doing research. Endermology versus liposuction with external ultrasound assist. That was an article, right, that you wrote, or a study that you did? Let's see. Can you talk about that?
Yeah, that's a 20-year-old or 20 plus year old article back in the day where this technology came out, and we vetted it. We vetted the technology. In other words, we did a comparative study of um, different types of ways of doing body contouring. Um, I think that study was really part of the times, so to speak. It's no longer pertinent to today.
Okay.
Nobody does it. Nobody no longer does that. I mean, I also did a study comparing, which you're not privy to, but a study comparing different facelift techniques, and I found that. if they were performed properly, there was really very little difference in the improvement of people as long as they were done well, each type of technique. In other words, the techniques did not necessarily by themselves improve outcome. As long as you can, in other words, you can gild the lily many different ways, as long as it's gilded properly.
Hmm. So, if young surgeons today, how do you think young surgeons today can maintain artistry in an era where that's increasingly driven by technology and social media?
Yeah, it's hard. It's difficult. We no longer find people in our field wanting to go into, coming out of residency, wanting to go into private practice because private practice is daunting. Many people will just want a job and they'll work at a hospital. I find that the majority of our residents want to do that. They don't really want to go into, take the risk and go into private practice. Those that do um, sometimes have issues with overextending themselves with the social media, trying to advertise on those platforms. And those are double-edged swords. You have to be very careful because of HIPAA considerations. You can be violating someone's um, personal information. Doctors aren't allowed to reveal that. You know, uh, I go to just a party in general. I'm getting invited to a party with my wife. I blend into the woodwork. I don't even acknowledge a client of mine unless they acknowledge me.
Hmm.
So there's confidentiality that has to be uh, almost sacrilege to violate. So you have to be very careful. Just acknowledging a client, remember, you don't know what they've revealed and to who.
Yeah, that's an interesting
I've
observation.
had patients that come in and you know told their spouses one thing about what they were doing, and turned out that they didn't reveal that they were doing another major part of a procedure to their own spouse.
Wow.
So you have to be very careful.
So, on your marketing side, you said you really don't do any marketing. Is that right? You completely eschew any kind of marketing at all,
I have a website. That's about it.
and and that's about it.
That's it.
Well,
As a matter of fact, I'm thinking about getting rid of the website.
no kidding.
Honestly, yeah, next year. I'm thinking seriously about getting rid of it because I'm finding, people coming in, seeing things on the website and assuming I'm capable of doing all of that, right? And I get concerned about whether or not unrealistic expectations are created by things like that. So I'm considering getting rid of it.
So it sounds like
Really?
you just need to get your website just focused in on exactly what you do. Um, but if you're
Yes,
have a
maybe, but it's
yeah,
hard. It's hard because you want to cover the gamut of everything possible, right? But
so what where would you think your where would you like to focus? I mean, where would you prefer most of your clients come from?
my own client and
So, I mean,
doctors
what kind of
and doctors
procedures?
and physicians. Oh, well, I run the gamut of cosmetic surgery. There's things I'm really expert at, uh, eyelid surgery, nasal surgery, um, facelift surgery, breast surgery, body contouring surgery involving tummy tucks, so to speak. The
Hmm.
mommy procedure. So, there's things that I can do that are I would call my B class procedures. Those are my A class procedures. B class procedures would be, say, thigh lift or arm lift, things. And then there's C-class procedures that I don't do at all. I will never do. And, the bottom lift, the butt lift, whatever it's called, BBL, whatever they call it. I wouldn't touch. Fat grafting, I'm not an expert in, and don't don't touch it. Uh, I also feel that certain eyelid procedures I refer out where someone has a droopy eyelid. I refer that to one of our eyelid experts, ophthalmology experts. There's things that I refer out that I know I'm not an expert at, and another key procedure would be an otoplasty. Say, kid comes in or a person comes in with a prominent ear. I do it, but I'm not. That's not what I do for a living.
So, what would you say to a young surgeon who's starting out, and you say most of them are going to the hospital, and they're concerned about going into private practice. What would you tell them, since you haven't done a lot of advertising? There's so many plastic surgeons now. I don't because a lot of them are not really plastic surgeons or cosmetic surgeons, but there's so many in that are competing. There's really hard. I can see how it's really hard for a young person, young doctor who wants to do that, to start out without advertising. How did you do it without doing a bunch of advertising?
Find a mentor. That mentorship is very important. For me, it was Tom Reese. Find a mentor, senior person that you can trust, and work with that person. Tom was so kind to me. He was probably one of the most highly acclaimed cosmetic surgeons in 70s, 80s, 90s. And I trained under him. And he asked me to co-author a textbook with him, which became the Bible of cosmetic surgery. And so I co-authored the second volume with him. And so find a mentor. Mentorship is vital. And you talk to any business CEO, Jamie Dimon, you talk to any major business CEO, and they will tell you find a mentor and stick with that person. Learn a lot through them. That's the way to achieve greatness, I think, in any field. If you don't have that, I think you really are going to suffer.
So I think that about does it. Anything that you want to leave our audience with um, about plastic surgery in general? That
Yes, there is actually, if you don't mind.
No, yeah, go ahead.
I would like them to understand a concept that I have found to be very important when they're seeking out plastic surgery. Don't compromise plastic surgical care for convenience. Okay? It sounds like a simple concept, but I see it transgressed many times, unfortunately. Just yesterday, I took care of somebody who came out to see me from lives in Laguna Beach, California. She
Hmm.
wanted her eyelids done. I had taken care of her brother, her sister-in-law, and geography wasn't important to her. So don't compromise geography. Don't compromise your care because something is around the corner. All right, if this person's coming out from Laguna Beach, California for her care, she knows she can get it, and she knows she'll get what she wants, right? So
Hmm.
good care, don't compromise geography, whether it be money, if it's not if you can't afford it, save until you can afford really good care, you know. You only got one body out there, right? God only gave you one body. You better take care of it. Don't screw it up, all right? Because plastic surgery can really, you know, be very, very serious stuff, So don't compromise good care.
So on that, before I sign off, then on that same subject, how do you find a qualified? So you've decided for whatever reason, you have your own reasons that you are either unhappy with particular situation that you're going through, or there's some other reason why you want to undergo a procedure. How do you find somebody that's capable?
Ask around. You know, don't submit to ads. Uh, you know, ask around. You know, there is ways of doing that nicely. Um, that is probably the only way you can achieve finding a good person. Uh, I think you can ask friends, family, physicians, your doctors, right? There's plenty of avenues that you can pursue, but don't be shy. Ask around, right? Uh, that's the old way we used to do things, and it's
Hmm.
still, you'd go to the town crier, right? Uh, it's no different. Ask around. Don't be shy about that.
Okay, well,
Get
thank
a
you very
couple
much. That
consults too. Get a couple
yes,
consults. Really good people want you to get a couple of consults because we want you to jump on the OR table knowing you've got a good pilot taking care of you.
well, thank you very much, Dr. LaTrenta, for taking the time out to meet with me and share your expertise on here.
That
Really
was a
appreciate
pleasure.
it.
It was a pleasure. You have a good Halloween yourself.
Thank you. You too.
All right.
Bye now.
Take care. Bye bye.